Okay, hello and welcome to this session of support for doctors returning to work in the pandemic. Tonight we've got two excellent speakers, Shefaly and Sunit, who are going to talk to us about how we should approach the acutely unwell patient. Shefaly, are you ready?
Yeah, just one moment.
So while Shefaly's getting ready, I'll just say if anyone has any questions, please pop them in the Q&A tab at the bottom, and we'll try and answer what we can as we go along. And if there's anything that we can't answer, we can always ask our presenters at the end. Perfect.
Thank you, Lizzie. So I'm Shefaly. I'm one of the Oxford Respiratory Registrars. I'm going to take you all through an approach to the patient with a high warning score today. So our overview today is going to be looking at early warning scores, in particular the constituent parts and their purpose, and then going over the well-known ABCDE approach to assessing a patient who's deteriorating, looking particularly at assessment and management. My aim today is more to provide you with a framework to deal with a situation where you're looking at an acutely unwell patient, rather than to go into the specifics of clinical management, which will be covered in a number of the other talks, including the talk following us today, looking at the breathless patient. So just a little bit about early warning scores at the beginning. So these are track and trigger scores. In essence, they're tracking physiological parameters, and when the parameters worsen, deteriorate in either way, they trigger a response by generally ward and nursing staff. And the aim of these are to identify and respond appropriately to patients at a risk of deteriorating. So most commonly, the track and trigger score that you'll be aware of is the National Early Warning Score. This was introduced in about 2012 and updated in 2018. It's used across the country, including with ambulance services. Some trusts, including Oxford, use slightly different track and trigger scores, but for the purposes of today, we're going to go over the National Early Warning Score, and in particular the second version. The reason that this was brought out nationally was that there have been NCPOD reports showing that most cardiac arrests in hospital are identifiable, and a number of them, about 40% of them, could be prevented had physiological parameters that show deterioration prior to the cardiac arrest been acted on. So in most basic systems, I've said, is that they're scoring systems and they look at a number of different physiological parameters. So this is the most common one that you'll see. And in essence, this is a News 2 chart, and it goes through a number of different parameters. So starting at the top, we're looking at respiratory rate and then oxygen saturations. There are two different scales with News 2. The first is for normal patients who aren't at risk of CO2 retention, and the second, just below, is SpO2 scale 2 for patients who are at risk of CO2 retention. We then look at blood pressure and pulse as part of the circulation assessment, consciousness and the level of consciousness as part of the disability assessment, and then for exposure we have temperature. If you're using a paper-based system, you may well see these on the reverse side of your News score, which in essence shows how nursing staff use the different parameters to total up a score, and then use the different thresholds for the total score to trigger a response. The response is graded according to the score itself. A normal score doesn't require any response, but a higher score requires a high graded response. So it may be that a ward doctor is asked to come, or if it's a particularly high score, then it's an emergency response, which quite often will take the form of a critical outreach team, a medical emergency team, or rapid response team. whilst you're returning to work in your individual's trust, it's worth looking at what form that higher emergency response will take, so that you familiarise yourself with it and also aware of what role you might play with it yourself. There is also a trigger on the Muse chart as to how often observations should be done. And again, this is broad, but in essence, a score between 0 and 7 triggers a different frequency of monitoring of the observations, and then also looks at the appropriate clinical response that the ward staff are expected to trigger. So in terms of an approach to the patient with a high warning score, I'm going to take you through the ABCD approach. This is the simplest approach to use, and it's the most thorough approach to use. The Muse 2 chart has been designed in such a way that it takes you through the ABCDE, looking at the chart itself. Although this is going to seem like a very simplified system, and we've been taught this since medical school or as junior doctors in simulation, there's a reason for that. And the reason is that it can be used across any form of clinical deterioration. It allows you to find a very complex situation and split that into more manageable parts, despite the fact that you might not know a patient very well, and you might be put in a slightly exposed situation where you're asked to see an unwell patient without background information. If you use the ABCD approach, you will always be thorough and you won't miss anything important. You're keeping the patient safe, buying yourself some time while you're waiting that final diagnosis and management plan. Just a brief word, we're always taught to think about safety for us ourselves, and in the era of COVID that we're all coming back to, the most prominent feature of safety is probably your use of PPE and making sure you're familiar with what PPE you're to use and for the individual circumstances, which should be signposted depending on where you are working. So starting with A, in terms of airway obstruction, I'm going to take you through assessment in the first instance, to look at the different ways of managing it, and then thinking about some of the basic clinical scenarios that you'd want to run through almost as a checklist. So when I see one of these patients who's deteriorating as a GIM registrar, I start with airway obstruction, thinking about whether they're talking, are they using their accessory muscles of respiration, what does their breathing sound like, is there any evidence of stridor, or is there any wheeze or gurgling from the end of the bed. I would look at their chest wall and think about whether there are any paradoxical chest wall and abdominal movements. So seesaw breathing is what this is most commonly referred to. And then there's a very late sign, and it is a very late sign, thinking about central cyanosis. You might want to start to think about whether a patient who has airway obstruction has partial or complete obstruction. And the reason for that is to think about what sort of treatments you can offer. So starting with very simple ways in which to clear an airway. So you'd use an airway opening maneuver, such as a head tilt chin lift. And I'll show you on a slide in a moment, for those of you that haven't done that for a little while, what that looks like. You might consider airway suction, just with a suction catheter on the wall. And you may well need to consider an insertion of either an oral pharyngeal or nasopharyngeal airway. Again, we'll come back to that in another slide. If you're having to think about more advanced airway clearance, and I'm not going to go in detail with respect to these, but you're thinking about an LMA or an ET tube, then you need to find someone who has critical care skills, i.e. your on-call anaesthetist who can manage an airway for you. And the last part of airway obstruction is always thinking about oxygen and applying the appropriate oxygen, which may well be a 15-litre non-rebreathe mask in these circumstances. Moving on to a head tilt chin lift, so you can see that on the left-hand side of your screen. So it's a hand on the forehead and another hand under the chin, lifting the chin up, tilting the head back, and just opening your pharyngeal passage to allow anything that's obstructed in the soft palate there to fall backwards. And then a jaw thrust, again, so standing behind the patient with two hands underneath the angle of the jaw, and just tipping the jaw and the head back so you're opening the airway. In terms of your airway adjuncts, I'm sure you're all familiar with these, but you've got an oral pharyngeal airway at the top and a nasopharyngeal airway at the bottom. They come in various sizes and various colours. In terms of grading them, so the way in which to measure a Goodell or an oropharyngeal airway is on the left, so you use the angle of the lips down to the jaw, and then you insert it as on the right, almost backwards, and then twisting it so that it sits in a similar position to that you can see on the left-hand picture. With an MP airway, you'll measure that in a similar way, so from the edge of the nose to the angle of the jaw, and then the bottom picture shows how to insert that. If you're looking for some more information about these in terms of sizing and in terms of how to insert them, then my best resource would be to look at the ALS Life Support and Guidance of the 6th edition, which came out a couple of years ago. In terms of briefly going over causes of airway obstruction, so what you might commonly see on a medical ward would be CNS depression. You might have blood or vomitus in the airway, alternatively a foreign body. There might be infection or inflammation, or laryngospasm and bronchospasm. Now, these will be covered a little bit more in the resuscitation ALS lecture that's to come later. So moving on to breathing, so I'm going to start with my assessment. So my general assessment would be looking at the end of the bed for signs of respiratory distress, looking at the respiratory rate and the saturations. I'll be looking at the depth of the breathing and the pattern of breathing, assessing the chest wall for equal chest expansion. There may be an underlying chest wall deformity that tells you a little bit more about the patient and their past medical history, and there may be external drains which you would want to assess for patency. I'd move on and then assess breath sounds using my stethoscope, thinking about percussion and auscultation as well. In terms of assessment, as we go through ABCD, it's a fluid environment, and you'd be assessing and then asking for further investigations or ordering further investigations yourself. So just order the relevant investigations to that part of the ABCD algorithm. So obviously at this point, this will be an arterial blood gas chest x-ray, and you'd ask for continuous oxygen monitoring. You've already put on your oxygen as part of your airway assessment. You might consider at this point whether a patient needs bag mask ventilation or whether you need to use non-invasive ventilation. And again, the next talk will go on in a little bit more detail about causes of the breathless patient on a medical ward and the most appropriate treatment. So I'm going to move on here, not go into any more detail. In terms of circulation, you will have your pulse and blood pressure provided by the nursing staff. In terms of my assessment, I'll be looking at the colour and the temperature of the patient, assessing their capillary refill time, both peripherally and centrally, looking at their JVP and listening to their heart sounds. I would also look at other surrogate signs of a poor cardiac output, and in essence those are urine output if you've got a catheter, or a urine output chart to assess, but also a patient's level of consciousness. And the other thing just to consider at this point is whether there's any evidence for hemorrhage. So investigations that I would ask for at this point in time are in essence an ECG, and I'll cycle the blood pressure and heart rate monitor to make sure that I've got continuous observations. In terms of simple treatment, as you all know, you would want a large bore cannula, 2 if possible, and this would be a good opportunity to take off your routine set of bloods and send them off. You might be considering a fluid bolus if the patient's hypertensive at this point, and the general guidelines are to give a crystalloid fluid, warmed if possible. It's not always going to be possible on a medical ward, between half a litre and a litre over 15 to 30 minutes. If a patient has heart failure, you might consider a smaller bolus of 250 mL over 15 to 30 minutes. You might be aware that a patient has a history of heart failure, someone may tell you that, or you may have picked up some signs of heart failure on your examination that suggests that you need a smaller bolus. In terms of a target blood pressure, you would, if possible, aim for the patient's norm. If that's not known, then I'd aim for a systolic blood pressure over 100. As part of my continuous assessment, I would give a fluid bolus and then reassess this, looking again at their heart rate and their blood pressure. I might need to think about giving a different type of fluid. So if there's evidence of hemorrhage, then I might think about whether the patient needs blood products at this point in time. And if they didn't have an adequate response to those fluid boluses, they were still hypotensive, and they were still compromised by that hypertension, you need to consider the need for vasopressors of inotropes, So again, thinking about a high level of support and whether you need the backup of your intensive care colleagues at this point in time. When we move on to disability, we're in essence at this point trying to assess for level of consciousness. So we're either using a GCS score, a Glasgow Coma score, or the AVPU score, seeing if the patient's alert, verbal, responding to pain, or completely unresponsive. There are a number of factors that can obviously affect this. So the most common things to think about at this point are looking at the patient's drug chart. Have they had any sedative medications they've given recently? Do they need reversal of any agents? I'd use this opportunity to examine the patient's pupils. I'd look at the size of their pupils, consider whether they're reactive to light, and consider whether they're equal. And if not, is this new? What could be the underlying diagnosis? Do they need further investigations like a CT scan of their head once I've stabilised the patient? It's also an opportunity to check a patient's blood pressure, blood glucose. In terms of blood glucose, I'd act on a blood glucose of less than 4. My initial action would be to give 50 mils of 10% glucose. I would intravenously, I'd repeat that as necessary. There's not a target blood glucose to aim for, but in essence, you'd be looking at a blood glucose that allows the patient to regain their level of consciousness. If that's the primary cause for their loss of consciousness, you might need to repeat that 2 or 3 times to bring their BM up. And then finally, moving on from disability, you've now exposed the patient. So look for evidence of a rash, look for any evidence of hemorrhage, look at any external drains. So we've already talked about chest drains, but they may have an abdominal drain, they may have had any other recent surgery. Looking to assess patency, but also what's the fluid in there? Could that have contributed to the patient's deterioration? Once I get to the point of considering disability or exposure, I'll then recycle myself through. We've taken all the appropriate actions as we've gone through in terms of airway adjuncts, thinking about oxygen supplementation, thinking about IV fluids for blood pressure. You may have picked up an arrhythmia on an ECG and need to think about acting on that arrhythmia. Again, not going to go into particular detail about this. This will be followed up in the ALS talk, but you'd use this opportunity to assess what investigations you've got back, what they add to your diagnosis, but also how has the patient responded to your initial measures and what else can you do at this point in time. Once I feel that the patient's safe, I'll then move on to thinking about my definitive treatment. Does the patient need a high level of care? This is going to be dictated by whether appropriate ceilings care are already in place. Do they have a DNA CPR? Are they a likely candidate for ICU? If you don't feel they are a likely candidate for intensive care, but they haven't got that ceiling of care in place, this is your opportunity to instigate it yourself. So you may want to review the patient's background, update their family and put that ceiling of care in place. Or the alternative, of course, is that they need a high level of monitoring and therefore review by your intensive care colleagues and considering moving them up to a more appropriate area, whether that be level 2 care in a HDU or intensive care. So in essence, today we've just gone through an ABCD approach, which is the simplest approach to managing a deteriorating patient. As you go through, you'd be expected to assess the patient. You'd be expected to order the appropriate investigations as you're going through each stage of the ABCD and then manage them appropriately during that particular part of the assessment, but also run through the different areas continuously, ensuring that you're not missing anything, and at the end using that as an opportunity to look through previous bloods, look through drug charts, look through the patient's history, and then think about ceilings of care, thinking about whether they need a high level of monitoring, documenting what you've done and updating family, and of course then handing over either to your colleagues or to someone more senior who may well then re-review investigations and treatment the patient requires. And that's the end of my talk. I don't know if there are any questions that are coming through that we want to address.
Thank you so much, Shefaly. That was really useful. I certainly have learnt a lot, and I hope everyone else has as well. Sunit has been covering most of the questions, I think, as we go along. I don't know if anyone wants to raise their hand and ask another one. Yeah, so we've got a question from Phil Smith saying, what specific crystalloid would you use, Shefaly?
So my general preference would be for Hartmann's, but your other option, depending on what's available, normal saline would also be entirely appropriate. And I think I would generally go with whatever's most available to me at that point in time.
Kirsty Harkness, do you have a question? Won't. No, I'm sorry, it doesn't seem to be working. I think
we've had a question just about an arterial blood gas or a VBG, and I think that's a really helpful question that I didn't address earlier, but certainly an arterial blood gas would be helpful, and I'll take that as part of my breathing assessment. If they're not requiring a huge amount of oxygen, so if their SATs are above 94% and they're not needing any additional oxygen, I don't think a venous blood gas would be inappropriate at that point in time, and you take those with your routine bloods as you put a cannula in.
Thank you. We've got a couple of people asking COVID-specific questions, and I know that Sunit is going to cover that, so I don't want to spoil his talk. But if you still have those questions after his talk, please do feel free to ask them again, and we'll cover them. So if there's no more questions, I will say thank you very much. We'll take a little break. We will be starting the next talk on time, so the break will be a little bit longer than planned to allow for people who were only going to join us for the second session. But that just means more tea, which is more better. Well, thank you very much, Shefaly, for that wonderful presentation. Okay, hello and welcome back everyone to these returning doctors lectures. I have Dr Sunit Raja, who's a registrar in respiratory medicine here in Oxford, to present to us on how to approach the patient with shortness of breath. Thank you so much.
Hello. It's quite a broad topic, dyspnea. It's pretty much all of respiratory medicine. So I'm going to take a whistle-stop tour through how I would sort of view the assessment of the breathless patient, as well as some specific conditions, and then how it would relate to COVID patients. So brief outline of my talk. So as I mentioned, kind of general review of the acute respiratory admission with some specific information on oxygen, respiratory failure, what to do when you've got a deteriorating patient, and the kind of multifaceted approach to how you would assess suitability for escalation to intensive care. A run through of management of some specific conditions, and then a fairly brief talk on COVID-19 and respiratory failure and the current management and body of evidence surrounding that. So it's quite a dense slide, and I apologize for that. The reason that acute is preceded by the word subacute, it's because most of the time when you have a respiratory patient, they will have felt these symptoms before. So it's really important to get a feel for what underlying respiratory or cardiac conditions they have and whether they've been in this position before. And often that will give you the answer. With regards to your presenting complaint, you do want to know whether this is something that's been gradual or whether it's really happened out of nowhere, and the severity of their breathlessness and how that relates to them. I'll come into this later when we're assessing suitability for escalation, but exercise tolerance, what they're like normally compared to what they're like now. And you'll find a lot of patients will say something like, oh, I can walk miles, when you ask them how far they can walk, you know, when you ask them when the last time they walked miles was, they'll say 2 years ago, and I've been housebound ever since. It's really important to get specific, because that will inform their suitability for escalation to ICU. How do they manage on stairs, and how dependent are they on the activities of daily living, and how does breathlessness influence that? Exacerbating factors like paroxysmal nocturnal dyspnea. So are they breathless at night? How many pillows do they sleep on? Has that gone up recently? And orthopnea. And the associated symptoms with it as well, again, can really give you the diagnosis in one shot. Yeah, and that history is more or less all of respiratory medicine in a nutshell, if I'm honest. Past medical history, these are a lot of the contributing conditions towards breathlessness. So often it'll be a flare of an underlying respiratory illness. Sometimes it'll be progression of another system. And the drug history I find really useful, mostly because you'll have a lot of patients that come in and say, oh, I'm completely well, I haven't got any past medical history. And when you ask them what drugs they take, they'll give you a huge host of medications that again inform what the underlying problem is. Really important to ask whether these patients are on oxygen at home. More and more patients we find are on long-term oxygen therapy. Similarly, whether they smoke. Usually we would say a smoking history of greater than 20 pack years is what would define whether someone can have COPD. There is some variability in that. Similarly, I've amended my practice in the last 3 or 4 years. I ask now specifically about cannabis use. Cannabis does cause worse emphysema than normal cigarettes. I'm not going to labour the examination too much, because I think Shefaly's been through it in great detail. But with a focus on the respiratory examination, if you're doing a sort of focused respiratory examination, auscultation and percussion are going to be fairly key. Have a look at the pulse to see whether this is arrhythmogenic. And again, that can be because your underlying problem is being driven by fast AF or another arrhythmia, or it can be that they've gone into an arrhythmia as a consequence of their underlying condition. Blood pressure is important. So a low blood pressure may suggest sepsis. And if you do see someone who's hypotensive, look for whether they're suffering the effects of that. So end organ perfusion, specifically meaning, are they drowsy? Are they peeing? And this is not a hard and fast rule by any means, but a high blood pressure can be suggestive of heart failure. And you may often see a spike in their blood pressure before they then go into acute pulmonary edema. And that's just a slight nuanced way of perhaps delineating what's going on. Fluid balance is really important, again, from a sepsis perspective and from a heart failure perspective. CRT is the cap refill time, and JVP, their jugular venous pressure. Everyone forgets these. And I find that actually they're the most useful way of assessing someone's fluid balance. Feeling peripherally whether they're warm or cool, and not just are they cool at the fingertips, but how far up their arm can you feel before you find that they're warm again? Again, gives you some vague spectrum of their fluid balance. And then a quick review of the other systems. Chest X-ray, I think it's really important to always compare it to another X-ray if you've got one available. You'll find that raised right hemidiaphragm may have been raised for decades, and you won't know that if you haven't looked at one from before. Is there unilateral or bilateral pathology? And then when you're looking at the sort of specifics of the X-ray, the lines are something worth looking at. So lines within the parenchyma suggest reticulation or interstitial edema. That is a feature of COVID. And air bronchograms would suggest consolidation. So the red arrow points to some lines. I don't know if that projects very well. And the orange arrow shows some consolidation with air bronchograms going through it. If you've got dense consolidation with no air bronchograms going through it, that may well be because there's lobar or segmental collapse, because there is a lesion or a mass within the main airways blocking it off. Always check the borders really carefully. So look at the heart, see whether you can make out all the heart borders clearly. Look to see whether you can see the diaphragms. Look at the costophrenic angles for fluid, that may suggest heart failure. And similarly, look really closely at the pleura to make sure you don't miss a pneumothorax. And then the final bit is your systematic review. So looking at the bones for fractures, hilar for cancer or lymph nodes, and assessing any NG tubes or central lines and their position as well. again, you see those lines, you see those tubes, you might want to look for signs of an iatrogenic pneumothorax. Investigations. So routine bloods, I tend to believe that that's a full blood count, Usinese, a CRP, LFTs as a sort of minimum. I would normally expect for any acute admission they have a venous blood gas as well. Depending on the presentation, you may want to do a D-dimer, a troponin, and a BNP, depending on what assay you have locally. I think an ECG should happen for every respiratory admission. And I think the question was asked about an ABG before, when it's necessary. I would say if they're requiring oxygen beyond what they're normally on, in fact, even for your long-term oxygen patients, if they're requiring oxygen and admission, they ought to have had an arterial gas. It's really important to document, ideally on the ABG, how much oxygen you took that gas on. A PO2 of 16 is meaningless if you don't know how much oxygen you were on. And again, I usually do a double take and go back and check the gas again because I've forgotten to check one of the life-threatening parameters like a potassium, glucose, sodium, or hemoglobin. So make sure you have a really good look at the parameters that you're not specifically doing the gas for, but may get you in trouble if you don't see. And then microbiological studies, so a COVID or a flu swab, if that's the type of patient you're seeing, sputum, send it off, and a pneumococcal and Legionella antigen if your curve score is high and you're looking at a pneumonia. And then general management for these patients. So we'll come on to oxygen a bit later, but broadly speaking, those are the target saturations you should be aiming at. If the patient's wheezy, then salbutamol 2.5 milligrams. That is really, I mean, really you can give that quite safely without causing too many adverse effects. Now, obviously you keep an eye on the heart rate, and if it's going up and up and up, that's time to stop. But if they're really wheezy, my tendency is to believe that in a non-cardiac patient, B comes before C, and you really want to get them breathing properly if they're very, very wheezy. Atrovent you can give 4 times a day, and it's 0.5 milligrams, and steroids 30 to 40 milligrams in airways disease. Look out for arrhythmias. So fast AF in general, you'll manage with a beta blocker if they can manage it. And if they can't, you can give us a dose of digoxin intravenously. Have a look at the potassium beforehand on the venous gas, because that can cause digoxin toxicity if it's low. If you've got an unstable patient, you may be using amiodarone or cardioversion. But again, I'd refer you to the ALS algorithm for more information surrounding unstable arrhythmias. If you think they're overloaded, then diuretics, so furosemide, 40 milligrams intravenously is the way forward. Have a look at their blood pressure to be sure they can tolerate it. Paradoxically, often patients who are overloaded and hypotensive may actually show blood pressure improvement if you diurese them because of cardiac improvement in cardiac filling. And again, have a look at their renal function beforehand. Logistics of urination really is being considerate towards our nursing and HCA colleagues. If they're due for a catheter, then don't ask them to have a dose of diuretic beforehand, and think about how they're going to have to pee, because it's not very nice for the patient or for the nursing staff to have to cope with that afterwards. And similarly, so the peak onset of furosemide orally is about an hour. Intravenously, it's a little bit less. So it's really important as a diagnostic test to see what the effect of your diuretic is. Has it actually helped? Because if it hasn't, it may well be that you're looking at a different pathology, or you haven't given enough diuretic. Infection and sepsis is, again, as it says on the tin, give broad spectrum IV antibiotics per the local protocol. And for PE, low molecular weight heparin, according to your local guideline, it's worth considering the bleeding risk. So usually the national guidance says CTPA should really happen within 24 hours for every admitted patient. If you feel you can't empirically anticoagulate those patients, then they should have a CTPA sooner to define what's going on. With regards to PE, I'm making a few shameless plugs. This app is fantastic. I don't remember a well score, and it's worth downloading this. It's free of charge, comes on all smartphones, and it will calculate the well scores and a number of other scores that I'm talking about later in the presentation for you. And really the overarching questions I'd ask myself then are, what is the diagnosis? Are they critically unwell, and do I need help? So that might come from a senior, from the respiratory team, or from cardiology. It might come from the intensivists. And I'll also be asking whether they need CPAP, NIV, or high flow nasal oxygen. I'll put that in brackets because it's a bit controversial surrounding the COVID patients. And then really I'll ask as well, can they go home? So if they're unsupported from a cardiac and a respiratory perspective and they're cognitively intact, more often than not, you will be able to get them home. And that's even with some of the more sinister diagnoses. They use the Curb 65 score to assess, well, to define whether you're going to admit some of your pneumonia patients. I suspect elements of this will be relaxed. So if you've got CKD or you're 66, you know, it's worth having that thought about whether these patients are good to go home. Oxygen prescription. So in general, if you've got a patient who's sort of normal, and by that I mean not a chronic respiratory patient, your target saturations will be 94%. In some patients who are known to have chronic respiratory disease, they may have lower sats, 90 to 92%, and be absolutely fine with it. If you're using an electronic system and you have cardiology or respiratory letters available, and you can see this patient walked into clinic in 2016 with saturations of 91% absolutely fine, that may suggest that they're okay to go home with similar saturations if they're okay for other reasons. If you're thinking about discharging these patients, it's worth clarifying with a specialty or with a senior first to make sure they're happy. And the key thing is that patient should not be breathless. If someone's breathless with sats of lower than 94%, then they need oxygen, they need admission most likely. Chronic ventilatory failure patients. So that refers to patients with COPD, obesity, hypoventilation, or neuromuscular disease. It's not every patient with these conditions, but it's patients who are predisposed to developing hypercapnia or high carbon dioxide levels. For various physiological reasons, if you give them too much oxygen, they will become hypercapnic, eventually acidotic, and they will narcose, they'll become very drowsy. The way to tell is first and foremost, ask the patients, are they on a home NIV machine? Have they been on NIV before? And similarly, when you look at your blood gas, have a look at what their carbon dioxide is now. So if it's above 6.5, then you know they're at risk of hypercapnia and you should target the saturations lower. And if their bicarb is above 26, 27, you'd be saying, again, they are at risk of hypercapnia and you would titrate them to lower sat of 88 to 92. If you're not sure, then I would oxygenate them normally and repeat a gas within an hour of having put, in an hour of having put them on that amount of oxygen. So target 94% and repeat a blood gas. It is time consuming, it is laborious. It is a lot less laborious than putting that patient on NIV and having to do 7 more gases on them over the next 24 hours. In terms of how we deliver oxygen, I think respiratory doctors go on and on about this. If you've got a critically unwell patient, they'll be on 15 litres of oxygen. That will provide anywhere between 60 to 100% oxygen through the mask. Nasal cannulae, you can't really define how much oxygen the patient is getting. It gives you a flow rate. It doesn't give you a concentration of oxygen. And you can use that for patients who are in mild hypoxic respiratory failure, usually people who are at the beginning of their kind of patient journey or ones who are kind of gradually winning down off oxygen. It is more comfortable, but if you've got an acutely unwell patient, it's not the best way of administering oxygen because you don't know how much you're giving. Normal face masks, I virtually never use these because again, you don't know how much you've got a lack of comfort for the patients because their whole face is covered and you don't know how much you're giving. It is used in moderate type 1 respiratory failure, mostly because someone's not thought to use a Venturi mask or they've run out of them. And then your Venturi masks go up in degradations from 24%, 28% up to about 80%. And it gives you an exact idea of how much oxygen you're giving them. That's preferred for all patients who are at risk of hypercapnia, so the COPD, neuromuscular, and obese patients we were talking about from before. And I would say it's also preferred in your normal hypoxic patients as well. I talk a lot about respiratory failure. So type 1 respiratory failure is hypoxic respiratory failure. Your typical pathologies will be pneumonia, pulmonary emboli, and early heart failure. And it refers to a low PO2, less than 8 on room air, with a low or a normal carbon dioxide level. Type 2 respiratory failure refers to hypercapnic respiratory failure. These patients are still as hypoxic, so a PO2 of less than 8 on room air, but they have a high PCO2 over 6.5. And this really refers to failure of your mechanical pump, so failure of ventilation. This would traditionally be COPD patients. Severe and really acute heart failure just causes mass impairment of gas exchange and ventilation, and obese patients. And the one to really be aware of, and this again is you'll see this with some of your COVID patients. if you've got a patient who is working hard in type 1 respiratory failure, obviously you can only keep that up for so long before you begin to tire. And once you begin to tire, you will start to see that you're not clearing your carbon dioxide well enough. That will rise and you'll go from type 1 to type 2 respiratory failure. In a patient that's for escalation, that is more or less an immediate indication for intubation or respiratory support. Certainly it requires a call to intensive care. A whistle-stop run through ABG interpretation. So the first thing that I tend to look at is the pH. What's their pH? Are they acidotic? If they're acidotic, I have a look at the PCO2. Is it a respiratory acidosis? And that would be informed by whether the PCO2 is high. If they've got a low or a normal PCO2, it suggests a metabolic acidosis with or without respiratory compensation. After that, have a look at their oxygenation. So the first thing is, are they actually in respiratory failure? And if they're not, have they been hyperoxygenated? So if they've got a high PCO2 and a really high PO2, the answer is relatively simple. You can wean the oxygen down and repeat the gas. Next thing, common sense, check if the gas is arterial. So on the gases that you get, you'll see an SaO2 or a SAT on the gas. Does that correlate with the SATs on the probe? And then finally, have a look at their metabolic status. So bicarbonate-based excess will tell you whether there's an element of chronic respiratory acidosis, and have a look at all the other parameters, so the life-threatening ones as well. I've covered that already. I'm not going to say that again. So in a deteriorating patient, I'll labour this point a fair few times, but it's really important to assess appropriateness for escalation. So is this someone that you would refer to intensive care? Is this someone that you would want to put on non-invasive ventilation on the ward? Most importantly, if you're not comfortable with what's going on, get some help. My understanding of most trusts during the sort of times of COVID is they understand the skill mix that's going to be available, and advanced respiratory therapies, even on the ward, will be consultant and specialty decisions. So if you're not a respiratory clinician, if you're not a cardiac clinician, if you're not an intensivist or an anaesthetist, you may not be making decisions. You probably won't be making decisions on CPAP or NIV, and that will be taken by those specialties. This is by no means an exhaustive list of reasons to refer to ICU, but I would usually say, kind of rule of thumb, if you've got if patient needing 60% oxygen, that's probably time to let the intensivist know, especially if that trajectory is one of deterioration. If you can see visibly that the patient is tiring, again, and you can see a rising PCO2, again, worth letting the intensivist know. If they are narcosed and drowsy with a respiratory element, again, another reason. Hemodynamic instability. Asthma is a particularly worrying one. If they have a normal PCO2 in asthma, the guidance is, and certainly the clinical experience is, that you should let the intensivist know. They don't need to take the patient necessarily, but they certainly need to be aware of the fact that they've got an acute asthmatic who's tiring. Severe respiratory or metabolic acidosis. So the guidance for NIV, and I suspect people will be a little bit lighter with this, given the capacity issues we'll have, is that NIV is most successful with the pH of 7.25 and above. If they have a pH lower than that, then the ideal thing to do is to refer to intensive care beforehand. But again, it's only worth doing that if you know the patient is for escalation, and similarly, it has some consideration for the capacity that the intensivists have. If you've got a patient who's been trialed on NIV and they're failing based on serial gases and appropriate management, then again, you'd have to let the intensive care unit know. Treatment escalation, I think we're going to have to be really hot on documenting these for all of our patients now, not just for the COVID patients, but for everyone. The approach that I tend to take, it looks at a few things. So first of all, what are their underlying comorbidities, and what organs are already failing to some degree at present? And that does include things like dementia. The way that I tend to explain it to families is that, it's not that we are being unfair for someone who's not cognitively intact. It's that dementia does not just affect cognition, but it also affects the brain's management of other organ systems. And therefore their survivability for escalated care is reduced. What their functional status is when they're well, and be really, really specific here. So as I mentioned before, some people will say that, oh, she does everything for herself. And when you ask when grandma did that, actually it was 6 months ago, and she's really been declining a lot since, and everyone's been helping her out, and that's relevant. whether they've had previous advanced therapies or critical care, and whether decisions were made at that point in time about re-escalation. And it is very deliberate putting patient and family wishes last in that approach, because I think, and that really refers to the last line, this is ultimately a clinical decision, and we're informing families of what's happening, why we're making these decisions. And it's important we do that in a sensitive way. But again, with the anticipated influx of patients, I don't think this is something where this isn't something where we'll have the luxury of convincing every family to come round to our thinking. And fundamentally, it is our responsibility, as clinicians, to make this decision for our patients. Document it really clean in the notes. If there is controversy, and there may well be sometimes, I personally think it's still worth documenting that you've had a discussion, nothing's been formalized, but in your opinion, this is what's going on, and this is what you've discussed with your consultant. So at least the person coming in after you can understand what the dynamics have been, and make an appropriate call if that patient deteriorates. So looking at specific conditions, I'm not going to run through the whole management over and over again. Pneumonia, fundamentally, the treatment is antibiotics, and you'll gauge that according to a curve score. It will traditionally cause hypoxic respiratory failure, but with enough time untreated or deteriorating, they will convert to type 2, and that does require intubation or intensive care as an ideal management form. Complications to look out for normally from day 2 or day 3 onwards are parapneumonic effusions, empyema and lung abscesses. This isn't something which you'll have to manage in the acute phase, and it's something which the specialties should be dealing with. Acute COPD, so I would advocate, if you feel like an acute COPD patient needs to come in, they do need an arterial gas. Similarly, most of these patients have a venous blood gas. I have lost count of the number of times that a patient has come in with a mild respiratory acidosis on a venous blood gas, has been started on NIV, and actually an arterial gas would have shown they don't need NIV at all. So arterial gases are really useful in these patients. If they come in with hypercapnia, then really strict with target saturations, 88 to 92%. Often they will have had 15 litres in the ambulance, and you'll need to wean that down carefully. If you do come across that, it's worth mentioning, wean down the oxygen slowly. So if they came in on 15 litres, give them 15 minutes on 60%, then 10 minutes on 35%, wean them down slowly, because they can develop quite a severe rebound hypoxia if you bring them down from 15 litres all the way to room air. Aggressive bronchodilation. So if they're wheezy, and I probably should have put that in the slide, if they're wheezy, there really is not much of a limit to how much salbutamol you can give them. So just, if they've got refractory wheeze, really get the salbutamol into them. Atrovent or ipratropium, the dose is 500 micrograms, and you can give it a maximum of 4 times a day. Again, with the salbutamol, I'm laboring that point, but I would say just have a vague awareness for a predisposition to cardiac arrhythmias or a cardiac history. Obviously, those patients you don't want to give too much, but you do want to get on top of their bronchospasm. Steroids, the dose is prednisolone 30 milligrams, and if they can't take it orally, give hydrocortisone. Aminophylline, I think by the time you get to this point, if they're for escalation, again, worth mentioning to the intensive care unit, but certainly worth mentioning to your senior and the respiratory team. It has actually fallen off the guidance because of the risk of cardiac dysrhythmia. But if you're backed into a corner, it is quite a useful drug to have. It's just important to have considered, the potential for tachyarrhythmia. The loading dose is there, and if they've got a persistent acidosis, hypercapnic acidosis with titrated oxygen and at least 1 hour of medical treatment, then they may need to start NIV. That 1 hour of medical treatment, there's an asterisk next to that. If a patient comes in and they are completely narcosed and you've ruled out other causes for it, it may be needed to start NIV sooner in combination with the other treatments. But the main thing to mention is don't just start NIV independently. You have to give them non-ventilatory treatment as well. For all patients that start NIV, regardless of the underlying cause, they have to have a treatment escalation plan documented in their notes, and so we know what we're doing if it fails. NIV will be set up, initiated by specialists, especially the COVID patients on NIV. It is aerosol generating, so they do need to be isolated. And because of the resource implications, it will be, as far as I understand, most trusts have said it will be a consultant decision, or they should really provide clear guidance on when to start it and which patient cohorts to start it in. If you are asked, to amend settings for it, again, I would probably suggest kind of some specific training on that from whichever trust you're going to be working in. But broadly speaking, if they've got a rising PCO2, wean the oxygen if you're able to, or increase their IPAP. If they've got a low PO2, increase the oxygen or increase their EPAP. You should aim to titrate their pressures first rather than amending the oxygen. And general target pressures, if you're not sure, is an IPAP of 20 and an EPAP of 5. Don't start NIV until you've ruled out a pneumothorax, because it will make it worse and there will tension. It's worth reviewing your local guidance on NIV. This is the BTS algorithm for NIV. Again, it's just useful to know what the contraindications are and what the indications are globally. Most of the absolute contraindications relate to upper airway issues. You can't give non-invasive ventilation if your upper airway is obstructed. Acute asthma. So a lot of the management is the same as COPD. The one thing I would say is asthma is a lot more unpredictable and they deteriorate rapidly, and it's frightening because they're young. Peak flows can be used to guide severity and whether they're going to be discharged, but don't ask a patient who is gasping for air to give you a peak flow. It's pointless. The steroid dose I use is slightly higher. That being said, there is a tendency to go for 30 milligrams in these patients as well. Really aggressive nebulizer therapy. So there's one more to back in those parentheses after the salbutamol. So you can give really aggressive salbutamol therapy to these patients if they are very, very wheezy. There is, some people do give 5 milligrams. There's no real evidence that giving a higher dose of salbutamol actually impacts anything other than tachycardia. In very tight asthmatics, sometimes the prolonged duration of a 5 mil nebulizer seeps through the airways a bit better and bronchodilates them a bit better. But again, that's very anecdotal. If they've had no response to nebulizers, then you can give them magnesium sulfate, and the dose is documented there. There's very few side effects. Often nurses will be quite worried about giving that off a monitor. I've yet to see any arrhythmias develop as a result of magnesium. Usually it's given to help resolve arrhythmias. But again, it's just worth being aware that sometimes they will need a cardiac monitor, depending on trust policy, if they're going to give magnesium. If they are persistently wheezy or hypoxic and have increased work of breathing after the magnesium, then again, aminophylline with the same sort of extenuations that I gave for COPD. And at that point, I would certainly be letting intensive care know. If you've got an asthmatic who comes into hospital requiring oxygen, and by that I mean requiring oxygen beyond their initial emergency management, I would want a blood gas for them in a normal or high PCO2. So a normal PCO2 is not an immediate indication for invasive mechanical ventilation. That's a typo. But certainly a high one in the context of a tiring patient needs intubation. That is some guidance on the severity of acute asthma. You don't need to learn this. It's just a guide. And similarly, if they look unwell, they probably are unwell. It's on MD Calc. I would suggest you download that. PEs, I think PEs is going to be really, really tricky because we know that some of the COVID patients that were coming in will present with isolated hypoxia and low SATs. Broadly speaking, your symptoms from a PE will be dyspnea, chest pain, and very rarely hemoptysis. It is worth asking all of these patients, if you suspect a PE, ask about whether they've been lightheaded or whether they've fainted. That is very frequently a sign of a massive PE that could cause circulatory collapse. And in the same vein, always have a look at their blood pressure. If you're hypotensive with a PE, your mortality is significantly higher. Normal chest x-ray. So, if you've got a patient who is young and well and they've got a normal chest x-ray, then, your index of suspicion for a PE is higher. Similarly, if you've got someone who's got chronic respiratory ailments and actually the chest x-ray looks largely unchanged, then it's worth considering a PE. If with the COVID patients, it's quite hard because if they've got a normal chest x-ray and they're hypoxic, yes, it may well be a PE, it may well be COVID. I think the only way you'll know that is if you do a CTPA. Things will push you one way or another. If they've got a CRP of 275, again, that's probably more likely to make you think infection. So you need to ask about negative symptoms as well for PE. So find out if they've got a sore throat, find out if they've got a cough, productive disputes, and take a full history. And really, once you've established that there's no other alternative diagnosis, then think along the lines of PE. Worth asking if they're already warfarinized or on a DOAC, because if they are, again, extremely unlikely they've got a PE. If you're going to anticoagulate them, think about their bleeding risk. The Haspelet score is a good way of doing that. I've mentioned reperfusion therapy with thrombolysis. Again, this will not be you. It's just worth knowing when to escalate a query PE. This will be, your intensive care teams or your respiratory physicians or even your cardiologists. The SPESI score and the Hestia criteria can guide discharge, potential safe discharge of patients who are concerned for a PE or have a diagnosed PE. This is on MD Calc, really straightforward score to actually work out. If you score 1 or above, then it suggests that you should remain in hospital for it, unless you have a senior review that suggests you'll be safe at home otherwise. Heart failure, so relatively straightforward assessment. Look at their JVP, look for edema. Are they hypertensive and what's the symptomology? Patients can spontaneously go into heart failure, especially if they've had an MI or an acute coronary syndrome, but have a look for other causes of heart failure and make sure they're treated as well. So, have they got coexisting infection, check a CRP. Have we given them too much fluid for existing inpatients? Is this fluid overload from a renal cause or liver disease, or do they have a valvulopathy and it's reaching critical mass? ECGs are really essential. Troponins will often be elevated for other reasons in these patients, so you want to see if there is electrocardiographic evidence of an MI. Your BNP, your troponin, can often be unhelpful in a sort of multi-morbid patients because they're raised in lots of other conditions, especially renal failure. But if they're astronomically high, it's useful and it can guide a conversation with a cardiologist. There is chest X-ray variability in heart failure. I think it's going to get quite confusing again for the COVID patients. So the first chest X-ray is more reflective of acute left ventricular failure. So that's when you just go suddenly into acute pulmonary edema. It's the kind of frightening, give morphine, give great whacking doses of furosemide, 15 litres of oxygen type failure. And again, it's worth having an awareness because some of the coronavirus patients will have bilateral infiltrates on chest X-ray and they will look similar to this. So really do a good fluid balance assessments and try and work out actually, could we sneak a bit of diuretic and will that help? And if it does, is this a patient we can treat with more support, with heart failure therapies? And then the other one is your sort of more chronic heart failure patient where I don't know if you can make out, but there's a very large, there's cardiomegaly clearly on the X-ray. You can't see the diaphragms, you can't see the costophrenic angles. There's lots of interstitial infiltrates. And that's someone who ought to have a go at some diuresis. Acute management of heart failure, morphine often gets forgotten. If you've got a really distressed patient, then give them some morphine, alleviate their distress, but it also does treat the underlying problem by vasodilating them. Diuretics, as mentioned, and make sure you treat the underlying cause. So if they are having an acute coronary syndrome, assess their bleeding risk. And those are the medications most commonly associated with ACS. Locally, everyone will have different policies, so please check that. It goes without saying, if they're on fluids on the wards, then stop the fluids. If they've got heart failure beyond that acute management, they may need a GTN infusion. And at this point, again, you want to seek specialist or senior input. If they need CPAP, so positive pressure, the way I think of it is really just to push the fluid back into the lungs and help vasodilate them a bit more. Again, that's going to be senior and specialty input. Pneumothorax. I'm not going to talk through how to put a chest drain in. I'm going to talk through really the hyperacute emergent management. I think as a frontline clinician or as a first presenter, as a sort of first responder, your responsibility is to identify a pneumothorax or raise concern if you can't be sure, and to be able to, well, as best as you can, manage attention pneumothorax. So for attention pneumothorax, it's defined by tracheal deviation away from the pneumothorax and hypotension. If they're hypotensive, it suggests that it's attention and they're about to arrest. It should be a grey cannula in the second intercostal space on the side that you suspect the pneumothorax in the midclavicular line. Review all of your x-rays really carefully. This is another thing that I walk back into the office and have a look at the x-ray again to make sure I haven't missed a pneumothorax before I send patients home. Just make sure you've looked really carefully at things like the apices, the kind of pleural borders, to make sure you can't see a rim that's in pneumothorax. And be really careful of bullous emphysema. So I doubt you'll get many x-rays that are as obvious as this. Now, on the right, you can see that there is a huge hole in the lung. The trachea is central, it's not deviated at all. But actually the reason that we know that that's probably not a pneumothorax is because you can't see a lung edge the same way that you can on the second chest x-ray. So if you can't see a lung rim and the patient seems oddly well for what looks like a huge pneumothorax, it's probably not a pneumothorax. And if you're not sure, ask for some input and an opinion on the x-ray. And if no one can decide, then just get a CT. If it's a pneumothorax in someone who's got COPD and they look remarkably well, it's probably not a pneumothorax. Pleural effusions, again, I'm not going to go through when to drain and lights criteria and specific medical management of pleural effusions. The main thing is that if they've got bilateral effusions, make sure you look for a systemic cause that's readily treatable. So if they've got bilateral effusions, it's probably going to be heart, renal, or liver failure, and it will respond to diuretics. It's worth checking things like a BNP, taking a cardiac focused history. If there's a unilateral effusion, it's still worth looking for a systemic cause. So if they're massively overloaded, they've got a huge right effusion, their JVP's up, treat them for heart failure, treat them for the causes of a transitive effusion, and see if they get better. Ask about clinical features of cancer or infection. If you think it's an empyema, then give intravenous antibiotics. If it's cancer, and I'll come back to this in a moment, then really what they need is oxygen until someone can take some fluid off, and that will be a pleural specialist nurse or a member of the respiratory team. The aim should be to take enough fluid off that you can get a diagnosis and send them home by sort of taking off 1.5 liters, and they need to go on the lung MDT. When you see these patients, you'll be doing a lot of x-rays, there's probably a lot of CTs flying around, and I suspect there will be a lot more incidental cancer findings. The main thing is if they're going to stay in, document this really, really well so it's handed over and not missed. I know that a lot of trusts are now hot reporting as many chest x-rays as they can, and if one comes back to you where it says there's a mass or there's a nodule in the left upper lobe, it's worth just emailing the relevant secretaries of the team or the relevant team or the MDT coordinators to make sure these patients don't get lost. Often I will ask for feedback from the person I've emailed just so I don't have that anxiety to slip through the cracks. Sorry, I'm going quite fast paced, but I'm going to run through COVID now. So 15% of all coronavirus patients will need hospitalization, usually due to respiratory failure, pneumonia, and sepsis. Some patients develop a myocarditis later in their illness. 5% of patients may progress, well, 5% of these patients may progress to acute respiratory distress syndrome. And this will almost definitely need intensive care input if they're for escalation. And that is why understanding whether this is a suitable candidate to step up is essential. The way we define ARDS is bilateral infiltrates on a chest x-ray that is not completely explained by cardiac pulmonary edema, an acute onset, usually 7 days, and a high oxygen requirement. And the PF ratio is a term they use on intensive care that's not really relevant to us. But again, if you've got someone who's acutely hypoxic that fulfill those criteria, chances are they're an ARDS secondary to their coronavirus. That is a typical looking x-ray, so you can see there are bilateral infiltrates, there's lots of lines, so this patient's probably on ICU. In terms of the clinical syndrome, almost all patients have a cough and will at some point have had a fever. Anosmia has been well documented earlier in the illness, and then other flu-like symptoms. Dyspnea is a really worrying sign. Aguesia means loss of taste, so that does go hand in hand with the anosmia, but it's worth asking about. In terms of blood tests, the lymphopenia is well documented, but it's not an absolute guarantee, so don't be put off the notion of it's COVID if their lymphocytes are normal. They can mount very high CRPs, and a slight rise in their AST or their ALT has been documented as well. Patients at high risk of COVID-19, I'm sure we've all heard about these. So if they've got fever and a cough, if you come across a patient on the ward who's got a low lymphocyte count and normal neutrophils, a classic x-ray, similarly isolated hypoxic respiratory failure, and the contact history, including travel to sort of a dense city in the UK now as well. There are quite a few patients who I've come across who have got no symptoms, are not hypoxic, but have a markedly abnormal x-ray that turn out to be swab positive. So really, all of these in isolation could suggest a patient who's got coronavirus. It doesn't necessarily mean they need rapid treatment or even admission, but it is just worth being aware of. when to swab, I suspect this will change soon, actually, but this is the current Public Health England guidance. So the first and foremost one is we're only swabbing inpatients. If they've got an abnormal chest X-ray in keeping with pneumonia, or the clinical syndrome in keeping with pneumonia, so that is going to be cough with or without sputum, temperatures, sore throat, ARDS as we defined earlier, or a flu-like illness. So it's an inpatient admission and any one of those three. I was on call over the weekend at a hospital which is now increasingly flooded with coronavirus patients, and the question's being asked, what do you do with a febrile non-COVID inpatient in whom you can't find another source? So will this now form part of our septic screen? The answer is I don't know, but I think it's always worth contacting your microbiologists and asking the question. If you're not sure about whether to swab, then ask that question. The test is not foolproof, so the swab sensitivity is about 75 to 80%. There is a reasonably high false negative rate. In combination with the CT changes, it's got a sensitivity of 95%, and those are the classic CT changes. So middle and basal ground glass changes, mostly peripherally. The swab sensitivity varies based on where you've taken it from and the disease course. So early in the disease, we know that it tends to affect your pharynx, and if you take a nasal swab or an oropharyngeal swab from there, it's more likely positive. Later in the illness, when you're breathless, we tend to get better results from lower respiratory tract samples. It's worth checking local procedure. If you've got somebody who's got a convincing CT and they've tested negative, do you send another swab? Similarly, if you've got someone who's got a very clear clinical syndrome, but their swabs come back negative, are you going to de-isolate them and stop PPE? It's worth asking the question of your microbiologist. And then the management. So first and foremost, please protect yourself. So the guidance broadly, and this will change from place to place. So again, check locally what you're doing. It's a surgical mask if you're not doing anything aerosolizing. It's an FFP3 mask if you are doing an aerosolizing procedure. I know there was a question about resuscitation. Resuscitation is an aerosolizing procedure. So as much as you can, you should be fully gowned and masked. In general, it will be get intravenous. If you're admitting the patient, IV access, oxygenate them, and I'll come back to that in a moment. So oxygenate them, routine bloods, COVID or a flu swab, and the chest X-ray. Everywhere I know is giving empirical antibiotics, check local guidance. And I know that it's been discussed about fluid management as well. So most of the data we have surrounding COVID actually comes from the ICU ARDS data and some Chinese data. The thinking is that conservative fluid management has better outcomes. That doesn't mean leave them hypotensive and uric. It means don't give them empirical maintenance fluids. Let them drink and try and avoid giving them too much drink. So for me, I'm kind of roughly estimating that I'm going to run them sort of to -500, -1 litre over the course of their length of stay. And I'm not going to give them additional fluids if they're normotensive, peeing reasonably well, and they can manage their own fluid balance. Similarly, avoid hyperoxygenation. I know we said normal saturations are above 94%. In this cohort of patients, we're aiming for 92 to 96%. That does not come directly from coronavirus data. It comes from ARDS data and some recent trials in ICU that have come out about ARDS. If you've got a patient who's running at 94% on whatever oxygen level, it's reasonable to leave them on that, but there's no need to gun for 97, 98%. Your patients that are at risk of hypercapnia, so this is the COPD, neuromuscular disease patients, obese patients who you've shown have a high bicarb, have a high PCO2, you should be targeting at 88 to 92% with low thresholds for arterial gases. The simplest management of these patients is always going to be, are they well enough to go home? One of the trusts that I've worked at looks at a new score of less than 2. The best thing you can do for these people is if they're well enough to get out of hospital, get them out of hospital. And if you're not sure, but you think they might be able to, have a chat with one of your bosses and see if they can get home, because that saves everyone an awful lot of trouble, and it's better for the patient as well. So these patients deteriorate really, really quickly, and it's sad to say that as a clinician, and I know that often the intensivists are increasingly feeling this way, that you feel rather helpless in what you can do for these patients, because it really is supportive management. And you will sit there watching these patients escalate on the amount of oxygen they're requiring over a matter of hours. Perhaps they'll try CPAP on the ward, And then they may be escalated to intensive care, where a similar pattern will happen. They'll have increasing requirements on the ventilator, higher levels of PEEP. So it's really important to ask yourself, not just for these patients, but all patients, suspected or otherwise, what will you do if they get worse? And all of these patients, everyone that's being admitted to hospital, has to have an escalation plan, not just for us, but for them. We need to make sure that anything we do, you know, intubation, renal replacement, whatever it is going to be in their interest, and we're not putting them through unnecessary suffering because they won't survive or because they'll be left with an appalling quality of life afterwards. So deteriorating COVID patients, trusts will have different policies for what they're going to do. If they're suitable for escalation, they've got an increasing oxygen requirement, call ICU. The vogue right now is the preference is to go straight to intubation as opposed to bridging with CPAP or NIV. If you've got a patient who's for ward-based care, there will be those patients who are suitable for a more advanced respiratory therapy like CPAP or NIV on the ward, and that decision should be made by an appropriate senior or specialty. There will be some patients who aren't for that level of escalation, and again, there may be some, I wouldn't suggest protocols, but there may be some discussion surrounding whether they benefit from early palliation. Highly comorbid patients, in general, cardiac patients, poorly controlled diabetics, immunosuppressed patients, they generally have a worse prognosis. This has been a really controversial area. I don't believe there's been any good evidence or guidance. So some high flow nasal oxygen has been pretty rapidly rolled out throughout the UK and a lot of hospitals. It's used extensively in the States, in Europe, and in China. It was used extensively in their coronavirus, in the Chinese coronavirus outbreaks and the Italian ones, partly because they're probably better resourced when it comes to nasal high flow oxygen. There's no mortality advantage. That does not mean it's worse. At the moment, the benefits are anecdotal, and that's the same for non-coronavirus patients. It is aerosolizing. We don't know whether it's more aerosolizing than CPAP or NIV. It's really controversial. I would check what your local guidance is, and just make sure you're PPE'd and these patients are appropriately isolated if you're seeing them. And this is just a finishing slide on really what the possible treatments are, hopefully sort of to leave us with a little bit of hope. So remdesivir is a protease inhibitor that was generated for Ebola. There's an RCT underway in China. There's a few RCTs underway in China. Some antimalarials with or without azithromycin has got some proven in vitro activity, and there's a big trial underway in the USA. Tocilizumab is a drug used in rheumatoid. The concept, well, the rationale behind coronavirus causing such a profound respiratory distress is a cytokine storm that happens around between day 5 and day 7 of the illness. Tocilizumab is an anti-IL-6 antibody that may dampen down that response. So there are trials underway through Roche. Lopinavir and ritonavir is a drug used in HIV. Again, some in vitro activity against coronavirus, and steroids are also in trials as well. I've adapted a lot of these slides from one of my consultants at Stoke Mandeville, so I'd just like to thank her for letting me borrow a few of them, and I'm sure there are some questions.
Thank you so much, Sunit, for that wonderful talk. If anyone has any questions that they're adding, I'll just ask them to put them in the Q&A, and I'll just run through the few that we have. I might also just unmute Shefaly and see if she can join us, and we'll have 2 experts on the panel, which would be even better. We've got a question about wheeze in COVID. Do you know, are COVID patients typically wheezy, and would you manage that the same as you would with COPD or asthma?
It's a really good question. So there's, again, anecdotally, one thing that we've seen is a lot of patients with existing airways disease, so asthma and COPD, actually strangely test positive for coronavirus and they're not presenting with wheeze. So the patients aren't necessarily wheezy. That being said, if they are, yes, I would manage them the same way, even if they're not known to have a wheezy, to have an underlying diagnosis of airways disease, and they present with a sort of bronchospastic syndrome related to coronavirus, I'd probably give them the steroids as well. That is based on case series evidence from China. It probably won't do any harm, and I think it's likely to open up their airways a bit better as well.
Thank you very much. We've got another question related to COVID. Are Venturi masks aerosol generating? Asks Anna Wilson. And I guess going over which oxygen delivery methods are AGPs would be really useful.
So none of the standard oxygen delivery devices are considered. So that's Venturi, nasal cannula, face mask, or non-rebreathe. None of them are considered aerosolizing. CPAP, NIV, and high flow nasal oxygen, which is a specific machine with longer nasal prongs, are all considered aerosolizing. Bag valve masking is certainly aerosolizing, that's kind of the point. And for some reason, pleural interventions are also considered aerosolizing. I suppose that makes sense as well.
Finally, I think finally so far, see if we'll get any more. Is there any specific advice for known COPD patients who then get COVID?
No, really. It's you know, if you're lucky enough to have a mild illness or be asymptomatic, do nothing and manage it conservatively. If you present with an effective exacerbation of COPD, then that should be treated as usual, but with really careful consideration as to whether you ought to be escalated to ICU if you deteriorate that badly. There's no specific change in management. They haven't changed inhalers at all for it.
I think there's a few questions concerning vaccines for COVID and COVID trials, which are probably a little bit beyond the scope of this basic general webinar, but we are trying to get a COVID-based webinar specifically together, and we should be able to do that within the next couple of weeks, cross fingers. If anyone knows any presenters who'd like to speak to us, please get in touch. But thank you very much, Sunit and Shefaly, for a really, really helpful talk. I'll suggest that everyone here takes the time to read through the many excellent answers to questions that are in the question and answer tab. And thank you very much.